Good morning, everyone, and welcome to the Opioids, Overdose, and Brain Injury series sponsored by the AdCare Institute of Maine and the BIA Maine chapter. Today's topic is clinical challenges of co-morbid traumatic brain injury and opioid use disorder treatment. The BIA Maine chapter gratefully acknowledges partial support for this training series from the Administration for Community Living, the U.S. Department of Health and Human Services, and the Maine Department of Health and Human Services. To ask a question, we please request that you put it in the Q&A box of your control panel, and at the conclusion of the presentation, I will read as many of these as possible to our presenter. Our presenter today is Dr. Chrystal Fullen, a clinical neuropsychologist serving the Department of Psychiatry, Neurology, and Trauma Surgery at the University of Arkansas for Medical Services. In her role, she has developed and co-directs a multi-tiered cognitive rehabilitation program at the hospital to foster interdisciplinary inpatient and outpatient rehabilitation of cognitive dysfunction, primarily in a TBI population, which also includes behavioral management of post-injury psychiatric symptoms, family psychoeducation to improve recovery, and brief psychotherapy to improve adjustment to injury outcomes. Welcome, Chrystal.
Good morning, everybody. Thank you for being here. As Peggy said, today we're going to be chatting about clinical challenges that are associated with comorbid diagnoses of both traumatic brain injury and opioid use disorder, and really focusing in today on the treatment of TBI and OUD. So I'm going to get us started. We have a little acknowledgement here from the Brain Injury Association. And let's talk about our objectives. So for today's presentation, this is part 4 of 4 presentations dedicated to the intersection of traumatic brain injury and opioid use disorder. So today we're going to start with a review. We've done this for the past couple of weeks, just really reviewing things from the previous 3 presentations. So what is traumatic brain injury, opioid use disorder, and overdose? What are the important things for us to remember about those? And then really today, spending a little bit more time just defining some of the commonalities and shared characteristics between traumatic brain injury and opioid use disorder. And then using that to focus on how we can identify barriers to diagnosis and assessment of these 2 conditions. We also want to speak a little bit more today about pain management dilemmas in this population, and then spend the majority of our time really addressing cognitive and behavioral challenges associated with integrating treatment for TBI and OUD. And then wrapping up by just touching on advocacy again, and highlighting the need for individualized care with this population. So without further ado, let's get started. We're going to start with that review of brain injury and opioid use disorder. Let's start with acquired brain injury. So this is a term that people use fairly often. And the best way to think about this term, acquired brain injury, is as like an umbrella term. All types of brain injury and things that can go wrong neurologically after birth, so acquired, not congenital, fall under this umbrella. So traumatic brain injury, or TBI, will fall under the umbrella of acquired brain injury. Another thing that does is infections. So, for example, things like herpes encephalitis, that would be a type of infection that could happen to your brain. Strokes are an acquired brain injury. Having a tumor or a space-occupying lesion in your brain is an acquired brain injury. Lack of oxygen or hypoxia or anoxia, same thing. And then other degenerative neurological diseases as well all fall under this umbrella of acquired brain injury. So thinking specifically about traumatic brain injury, what is traumatic brain injury? I have my favorite definition up there from the CDC and the Department of Defense, but really the simplest way to describe a traumatic brain injury is a blow to the head from an external force. So something that is impacting the brain, externally, whether someone falls and hits their head, or they're hit on the head by something, that external force causes a blow to the brain that is more than the brain is able to sustain with the skull and all the other protective features. And because of that blow, people will experience alterations in their mental functioning. So the way the brain works will be altered or impacted or interrupted by that blow. There are two types of traumatic brain injury that we speak about. We speak about open head injuries or closed head injuries. If you have an open head injury, it sounds like it is. This is where the skull and brain are penetrated. So something like a gunshot wound or a stabbing is an example of an open head injury. There is a higher rate of mortality with open head injuries simply because when you have an open head injury, you have something that is always encased by all these layers of protection that is now open to the environs, and it's not designed for that. The brain tissue is not designed for that. So there's a very, very large risk of infection. When you have an open head injury, you tend to have very focal impairments following that brain injury. For example, if someone is stabbed in the temporal lobe, it would likely be that they'll have very focal impairments associated with temporal lobe functioning as a result of that. When you have a closed head injury, you can have more diffuse impairments, meaning because the whole brain is maybe shaken or knocked about, or there might be swelling across the whole brain, you can have more diffuse impairments, meaning that multiple systems, multiple areas of the brain are impacted, and the things that they're in charge of can be different or change as a result of that injury. So with closed head injuries, same thing as open head injuries, it sounds like it is. This is when your skull and your brain tissue are still closed to the environs, but the damage still happens to the brain. This usually happens after things like a fall or a motor vehicle accident. Okay. Oops, sorry. Let's see. Okay. So what are some of the leading causes of traumatic brain injury? So right now, the biggest reason people have TBIs is actually due to falls. So people tend to fall almost half of the time, resulting in traumatic brain injury. Other things that are sort of high numbers is being struck by or against an object. This can happen because of a fall. This can happen because of a workplace injury. This can also happen because of assault. Assault is also a large number when it's just straight assault, and there's no objects involved, like a fist fight, for example. And then, of course, traffic accidents is another pretty high number of cause for traumatic brain injury. When it comes to traumatic brain injury and falls, one thing to think about is that the people who are most at risk for traumatic brain injury tend to be at the ends of the age spectrum. So younger children and older adults. And that's actually because those two age populations, they're a little more unsteady on their feet. And so the risk of them falling is greater. And because the risk of a fall leading to a TBI is pretty high, that's why those two age groups tend to sort of make up the most at-risk population. Despite the ends of the age spectrum being the most at risk for traumatic brain injury because of falls, the age range that tends to have the most traumatic brain injury are usually 18 to 24-year-olds. So 18 to 24-year-olds, that's when you're sort of allowed to start driving. That's where sometimes people start drinking alcohol. They're exposed to other types of drugs. They can, be in situations that might not necessarily be as safe. And so that is actually 18 to 24, the age range with the most traumatic brain injuries. Okay. So I want to talk a little bit about traumatic brain injury classification. We speak about this every week. I think it's really most important this week, just as a review, to note that we have three levels of severity for TBI. We have mild traumatic brain injury, which is also known as a concussion. A mild TBI is a concussion, and a concussion is a mild TBI. We also have moderate traumatic brain injury and then severe traumatic brain injury. There are a couple of different ways that we can tell as providers if someone has a mild, moderate, or severe TBI, and those are the criteria listed on your screen. So someone's GCS, which is a scale that is given on scene of an accident, usually on scene when an ambulance or EMS picks up a patient. It can also be given in the emergency room. The first GCS is usually the best indicator of head injury severity. And the GCS scale involves someone's best motor response. So can they move their body to command? Their best verbal response, can they speak coherently to you? And their best eye-opening response. If you ask them to open their eyes and look at you, can they do that? Can they direct their gaze? So those 3 levels of questions make up the GCS scale. The lowest score you can get on GCS is not 0, it's 3. You get 1 point for being able to not be able to do each one of those things. So the lowest score on a GCS is 3, the highest is 15. We also look at loss of consciousness or alteration of consciousness, meaning is someone disoriented, not thinking as clearly as they normally do, not able to follow along with things. We also look at post-traumatic amnesia, which is a state of being where people forget a little bit of what happened before their accident, and then are struggling to remember and pay attention to and track information following their accident. We call that period of time PTA. How long people are in PTA can help us determine head injury severity. It is also a very, very robust indicator for how much support someone might need after a traumatic brain injury. So if someone is in PTA for a week to 2 weeks, that tells us how much support they might need. If someone is in PTA for a month, that tells us how much support they might need. When people have PTA for over a month, it usually means that they will need assistance in their IADLs more long-term following their head injury. And then, of course, we also look at CT or MRI findings across the board. People can have no findings on MRI and still have a severe brain injury or a mild brain injury. But typically, when people have moderate to severe injuries, we do see findings on CT or MRI.
Chrystal, I'm sorry, I just have one quick question for you. Advanced percentages that you displayed, do those percentages include overdoses?
No, they do not. Okay, good question. There are some new findings, to Peggy's point, there are some new findings about suicide, including suspected intentional drug overdose and attempted suicides that are starting to really reach high percentage numbers for traumatic brain injury as well. So let's look a little bit at the TBI symptoms, the things that are most commonly noted after a traumatic brain injury. Now, as I mentioned before, you can have very focal symptoms, and you can have very diffuse symptoms after a traumatic brain injury. So anything that the brain does for the body, which is everything, can be impacted after a TBI. And that's why after a TBI, people can have very unique presentations. And despite the fact that we all have frontal lobes, we all have temporal lobes, and we know broadly what those parts of the brain do and how they support one another, because we're all very unique and we've grown up, nature versus nurture, our special ways, and all those different types of things. No 2 brain injuries ever look alike. So you can have 2 brain injuries caused by the same thing at the same age, same education level, same ethnicity, grew up in the same place, and they can have different symptoms. So thinking about TBI symptoms, know that we can have multi-system symptoms, which means multiple systems of the body can be impacted. We typically see somatosensory changes. Many people after TBI will struggle with things like headache that usually persists for at least 3 months following traumatic brain injury. People can also have a lot of fatigue. A big reason for fatigue after traumatic brain injury or any type of brain injury is that the brain is moderating your energy levels, right? And when it is focused on its own healing, it's pulling energy resources and really prioritizing that healing. So people will have a lot of post-injury fatigue. It can last up to a year following brain injury. People can have changes to any of their sensory systems. From a motor perspective, people can have weakness, numbness on one side of the body, trouble with balance, poor coordination, slurred speech. Cognition is a big factor, and cognition and psychological changes following traumatic brain injury tend to be the two biggest reasons why people with TBI don't always successfully return to work. Sometimes people have disability from mild traumatic brain injury. That is the same type of disability that people with severe traumatic brain injuries will also experience. And that's because of those variances in symptoms, and because of how much cognitive and psychological problems can get in people's way. With cognitive problems, we often find that people will struggle with attention and processing speed, and then we can have more specific symptoms depending on where the injury is. Most people, when they have a traumatic brain injury, tend to injure their frontal lobes. The reason for that is frontal lobes are right in the front of your head, right? They're also the biggest part of your brain. They're in charge of a lot of things. And so change, even if it's a tiny injury, tends to have an impact on things. You know, you might hit or hurt a part of the frontal lobe that's in charge of, let's say, regulating another brain system. And maybe that system is a motor and reward pathway. And so it changes the way that you learn, the way that you respond to feedback. And that can actually have a really big impact on a lot of things. Psychological problems after traumatic brain injury are common. We typically find that people experience some level of adjustment disorder, but up to 50% of people will experience depression in the first year after a TBI, and up to 67% will experience a major depressive episode within the first 6 to 7 years after traumatic brain injury. So that number actually rises. I wish we could all chat together about why that might be, but I'll tell you, one of the reasons is because after a traumatic brain injury, we have that initial period of time where there is some adjustment. And a lot of times people will think things are going to get better. They'll start feeling better. Some of their symptoms will get better, but unfortunately, they will still continue to have difficulties long term, and that will create that depression. Of course, many people, based just on the nature of their injury, like assaults, for example, car accidents, will also experience PTSD and acute stress disorder. There are a lot of behavioral changes that come with traumatic brain injury, partly because of the association with frontal frontal syndromes, the frontal lobes, how often the frontal lobes are injured in injuries, and their responsibility with our behavior. The frontal lobes are responsible for behavior in a lot of ways. So people can experience anosognosia. That's very common with right frontal and right parietal traumatic brain injury. So if you hurt the front part of the right side of your brain, and then kind of the top part of your head right about here, those are your frontal and parietal lobes, you can experience what we call anosognosia, which is not being able to recognize the symptoms associated with your brain injury. You have this loss of awareness of the change of symptoms, which can be very challenging, because if you don't believe that something's wrong, it can be super hard to get you to go to treatment and work on something. Of course, it can be impulsivity. There tends to be decreased social cues because of that impulsivity, increased substance use, also because of the depression, sleep disturbances, change to sex drives, changes to the way that people are able to respond to things like sarcasm and any kind of abstract language. Okay. Um, we also have another type of brain injury that's super important for us to talk about because we're talking about opioids today, and that's hypoxia and anoxia. So hypoxia and anoxia both refer to loss of oxygen in the brain. This is also, as you may remember from a few minutes ago, under that umbrella of acquired brain injury. So if you have a hypoxic injury or an anoxic injury, that is a type of brain injury. The difference between hypoxia and anoxia is hypoxia means you've lost some oxygen to the brain, and anoxia means you've lost complete oxygen to the whole brain. I like to remember it by H being half and A being all. So that's how I remember that as a little trick. But regardless, the brain uses a lot of oxygen. So even with 30 seconds without oxygen, unless you're an Olympic swimmer, people can struggle and they can lose consciousness, especially depending on their age as well. Once you get up to a couple of minutes, there can be extensive damage when the brain has lost oxygen. And there can be a lot of impacts to parts of the brain that use the most oxygen. So there are parts of the brain that are just always pulling for extra oxygen. Three main parts are the hippocampus, which is deep in the temporal lobes. That part of the brain is associated with memory storage. You can also have a lot of pulling for oxygen from the midbrain, the deep center of the brain, the basal ganglia, which people often hear about when they think about things like Parkinson's disease. And that part of the brain is responsible for motor. It's responsible for reward system learning, lots of different things. And then, of course, been talking about this a lot this morning, but the frontal lobes also pull for a lot of oxygen. So it wouldn't be uncommon for those three areas to take the most damage if people lost oxygen for a significant period of time. People tend to lose oxygen after things like a cardiac arrest or heart attack, drowning, assault, smoke inhalation. With assault, specifically choking, people also lose oxygen when they attempt suicide by hanging. And then, of course, a really, really big one and big in recent years is many people will lose oxygen to the brain due to overdose. Okay, with regards to hypoxia and anoxia, we have some unique brain injury symptoms based on those areas that I mentioned to you earlier, the hippocampus, the basal ganglia, the frontal lobes, because of what they're in charge of. We will see executive dysfunction. We can see memory problems. We can see very, very poor motivation. You know, very little sort of self-initiation. And then we can also see some apathy as well. And so this combination of symptoms can also make treatment really difficult for people with anoxic injuries or hypoxic injuries, not because they don't want to do it, but because they don't have a lot of that self-initiation. They don't have a lot of that, like emotional drive as a result of where their injury impacted, where that injury happened. So I want to talk a little bit today about TBI recovery trends. I think it's really important as we wrap up this series. There is a lot of different information. If you Googled right now, you could read papers and you could look at, different things, and you're going to hear about brain injury recovery in a lot of different ways. And people are going to make a lot of different statements about how long people actually have for recovery after brain injury. So when we think about TBI, and even if we think about anoxia and hypoxia, we think about recovery in two ways. We think about neurological recovery and functional recovery. The difference between those two things are neurological recovery happens, within the brain healing itself. And if you had to do something like, let's say, a neuropsychological test battery, at point one, immediately after the injury, and then at point two, let's say at 2 or 3 years after the head injury, you're going to see recovery. You're going to see that people have gotten better on those sort of objective tests. That's neurological recovery. Functional recovery happens when people may or may not have gotten better on objective tests, but they can do more for themselves independently and successfully. So functional recovery, from a quality of life perspective is arguably more important in some ways than neurological recovery. But if we look at just neurological recovery, hopefully you guys can see my mouse over here. If we look at cognitive level, everyone starts at a certain cognitive level before a brain injury. So let's say someone's here, maybe in the average to high average area, and this is sort of their pre-injury level of functioning, right? If they have a brain injury, whether it's mild, moderate, or severe, at that point of injury, their cognitive level is going to drop all the way down. People are going to be disoriented. They might not know where they are for a second. And again, it might only be a second, but that head injury is absolutely going to impact them. If it is a mild injury, they're going to shoot straight back up after, who knows, maybe a day or two, and they're going to get to around about their pre-injury level of functioning. And after not too long, usually with mild TBI or concussion, they should be back to pre-injury level of functioning around 3 months. That's neurological recovery right there. Not necessarily functional recovery, neurological recovery. For moderate or severe TBI, you can see that the same thing happens. People have a lot of rapid improvement in the first couple of months after their injuries, but they don't necessarily get back to pre-injury level of functioning. You can see moderate, there's quite a little bit of difference here where people are having ongoing cognitive problems, and then severe TBI, even more of a disparity between current level of functioning and pre-injury level of functioning. This graph goes to 12 months because back in the day, people were given 12 months for neurological recovery after brain injury. Now we know that people have up to 5 years. That's what new studies are showing, good, robust studies. Up to 5 years post-injury, people are still experiencing neurological recovery. I've said this before, if you're still experiencing neurological recovery, you're still experiencing active symptoms that are affecting, impacting your brain, which can have quite an impact on people. For functional recovery after brain injury, people are seeing changes, positive changes in functional recovery up to 15 years with ongoing rehab. Okay. So let's talk a little bit about some statistics in Maine. We had Patty last time with me, and she did such a wonderful job going through some of the specifics about Maine and OUD and TBI. So I'm just going to briefly touch on this. In Maine, we have about 5,000 folks every year who are sustaining TBIs, primarily due to falls, motor vehicle accidents, and sports-related injuries. This was a number that was taken in 2024. Hopefully 2025 will be less. There are some unique issues related to traumatic brain injury in Maine, mainly uneven resources. There are a lot of pockets of cities where we have good resources, and then other more rural communities where there aren't as many resources or no resources at all. And then, of course, for the providers in Maine, there are only a few providers who have specialized training in brain injury and opioid use disorder, but not necessarily everybody having that training. And that's actually pretty common across the country. Not a lot of people are specializing in brain injury or opioid use disorder, and very rarely both. Of course, for Maine, like other states, there is a high number of folks who unfortunately pass away or have to receive disability benefits after traumatic brain injury because they're unable to go back to work because of the severity of their symptoms. The number of people, I think it is, don't quote me on this, it's a little over 60%. I think it's like 66% of people with moderate to severe TBI across the country, the national average, who survive traumatic brain injury. So about 66%, I think, is the number. So not everybody survives traumatic brain injury. About 10% of the hospitalizations in the state of Maine every year are related to brain injury. And this includes TBI only, so not other acquired brain injury. So to Peggy's point earlier about some of the percentages for causes of traumatic brain injury, this does not include people who have overdosed. Sometimes those things are just tagged differently in emergency rooms. Let's transition to substance use disorder and opioid use disorder. With substance use disorder, we know that substance use disorder is, commonly referred to as addiction. We don't use that term anymore. The DSM describes substance use disorder as an uncontrolled and persistent use of any single or multiple substances that end up resulting in negative consequences, and that people continue to use that substance despite those negative consequences. The uniqueness of substance use disorder cannot be emphasized enough. There are very specific things that people have studied that we know make people more likely to develop a substance use disorder. Things like family history of substance use disorder, ACEs or adverse childhood experiences, early exposure to a substance, mental health diagnoses, and even traumatic brain injury puts people more at risk for development of a substance use disorder. But that true cause and the collection of symptoms that make one person versus another develop a substance use disorder is, again, very individualized, just like we said with traumatic brain injury. No two injuries are alike. There are some key features of substance use disorder. The first one being intoxication, so experiencing a drug effect from a substance. Tolerance, so over time, needing more of a substance to become intoxicated and have a positive drug effect that you're looking for. And then withdrawal, meaning that when you're not using that substance, you're experiencing symptoms that are making you feel really sick and making you want to use that substance again to get rid of that sick feeling. All of those key features are some of the more physical components of substance use disorder. There are also a lot of psychological components to substance use disorder as well. There are 4 categories that are needed for diagnosis of substance use disorder. The first one being impaired control. So again, not being able to control how much you're using despite difficulties. Social problems, so some of those difficulties, lost jobs, problems with family, financial difficulties, dangerous use, so experiencing some of those key features with intoxication, tolerance, and withdrawal, and then that drug effect, the drug actually having an effect on the person. And if we look at opioid use disorder, this is a substance use disorder with the primary substance being used that is opioids, okay? There are a bunch of different kinds of opioids that we all know and that most people are pretty familiar with. So oxycodone, hydrocodone, morphine, other illegal substances too, heroin, synthetic opioids like fentanyl, and then of course opioids also started out supernaturally in the poppy. So that's where sort of opioids naturally come from. For a substance use disorder and opioid use disorder, we need to have that problematic use pattern across a 12-month period for diagnosis. There are some unique aspects that make opioid use disorder super challenging to live with and super challenging to treat. One of the most important things is there can be physical dependence in as little as 4 weeks. I say this every time, so apologies if you've heard me say it before, but you get a prescription from the doctor, you're getting the prescription usually for a month, right? So if you fall at work, hurt your back, and your doctor gives you some oxycodone to help you on really bad days, you have that 1-month prescription. And unfortunately, that's all it takes with opioids. There are some significant withdrawal symptoms. We'll talk about that in a moment. Really significant symptoms that almost make it very, very challenging for people who are taking opioids not to take it again to get rid of those withdrawal symptoms. And as a result of that physical dependence, those significant withdrawal symptoms, people have increased motivation to use. So let's look at that opioid and opiate withdrawal timeline. Both are the same. When people will take their last dose, they'll actually have about a 72-hour period where there's this peak of physical symptoms. Typically, those symptoms are pretty gastrointestinal. People will have a lot of diarrhea, they'll have nausea, they'll have a lot of pain in their body. They'll also experience chills, fever, and body aches, so more of sort of like a flu-like profile. And then they'll even have things like dilated pupils as well. So really, really significant physical symptoms at 72 hours. The first time someone experiences this and they take another opioid and all of this goes away, that is a very, very powerful message that you've just sent to your brain that if any of this ever happens, this medication is, the magic thing that takes it all away. That sort of classical conditioning, that immediate connection can be very hard to resist when you start experiencing these symptoms again. About 1 week later, physical symptoms start to lessen, but if you still haven't taken another pill, you're going to continue to experience body aches, lots of fatigue, people will sweat, people still tend to have a gastrointestinal profile, but you can also have some anxiety and irritability, and we start seeing more of the psychological effects of withdrawal coming up. Those psychological symptoms continue to persist with depression, restlessness, trouble sleeping. And then even a month later, if you still haven't taken any medications, continued depression as well as some cravings. So withdrawal symptoms definitely linger for quite a while. So it's not like, okay, I don't know if anyone ever used to hear this, like back in the day when people would try to quit smoking, they'd be like, just make it 3 days. And if you don't have a cigarette in 3 days, you're covered. Well, that wasn't true for cigarettes, and it's certainly not true for opioids. So you can kind of see people are still experiencing difficulties here. So let's talk about those withdrawal symptoms. So like we saw, people tend to have aches and pains. The biggest reason for this is because most people who are taking opioids are taking it as pain management, right? They start out that way. Opioids work really well. They take that pain away. About 2 presentations ago, we focused on the sort of biological underpinnings of how opioids work. And we know that they work at the brain, at the receptor, blocking those pain signals almost completely. And so when you're not taking them, the biggest thing you're going to experience is rebounding pain because those signals are open again. Of course, people are going to experience sleeplessness. They're going to struggle with that. They'll have those fevers and chills, gastrointestinal symptoms, restlessness. They may feel agitated and anxious. They'll have that pupil dilation, lots of cravings. People can also experience elevated heart rate. They can experience increased blood pressure, which is pretty dangerous for people who already have high blood pressure. And then sweating we also see as well. So what are the warning signs of opioid use disorder? If you're worried that a patient, maybe a patient with a brain injury, is misusing opioids, what are some signs that might clue you into the fact that they could be potentially struggling with OUD? Well, one thing is somnolence, and that's tricky because a little while ago we said that when people have traumatic brain injuries, one of the things they struggle with for up to a year following their initial injury is significant fatigue. Somnolence is a little different than fatigue. Fatigue is sort of bone weary, can't get rid of being tired, whereas somnolence is like sleepy, tired, but still can be a little bit tricky to tease apart. You'll also notice some changes in sleep and exercise habits. And if this isn't coinciding immediately with the onset of a brain injury, you should be able to note the difference. Like out of nowhere, people will have changes to their sleep and exercise habits. Some more telling signs are those flu-like symptoms we spoke about when we were talking about withdrawal symptoms, weight loss, mood lability, that might be different than it used to be. Mood lability is also common after brain injury. But again, if you're imagining someone who had a brain injury and then develops OUD, you will see a little bit of an increase or a change. Decreased libido, inattention, isolation from family members or friends, that's a big one. New financial difficulties, stealing from family members, friends, or businesses. So very sort of strange behaviors for a person. All of those things can be signs. But again, I think if we were all chatting together and we had a little roundtable discussion going here, a lot of these things would not be necessarily uncommon after a brain injury too, right? I just said a few minutes ago, one of the biggest things people will share, regardless of injury location after brain injury, is attention problems. So it can make it very, very challenging. So what are the impacts of opioids on the brain? So we know about those multi-system symptoms associated with brain injury. What about opioids? So opioids also, especially long-term use, is going to impact your cognition. People have impaired learning, so they won't be able to take in as much information, as much new information as they usually could, and they'll struggle with remembering that information later on. People also struggle with poor decision making, so it's challenging for them to make decisions for themselves. People will also have difficulty regulating their emotions. And if you can't regulate your emotions well, you get stuck in a specific emotion for an extended period of time. So you can be upset over something small, get stuck in it, and people will be like, why are you so upset? Like such a small thing happened, but you can't regulate yourself out of that. So it'll really feel like a very pendulum type mood swing that happens throughout the day. With opioids, that really does tend to impact people's moods. So when you take an opioid, it creates a sense of pleasure, tends to induce relaxation. But when you come out of using opioids, as you saw, it can also increase your risk of and contribute to depression. So a lot of times when people are taking opioids, they're taking them because it helps get rid of their anxiety and irritability as well. But while it's doing that, because it's like depressing the brain systems to get rid of those pain signals, it's also increasing depression. With regards to behavior, as we said, opioids block pain signals. And so what ends up happening ultimately is people become more sensitive to pain because they can't self-regulate and manage that pain. The medication is doing that for them very, very well. And so when they are even in a little bit of pain, the idea becomes take this medication because it's sort of almost impossible to bear even small amounts of pain. Of course, we have that physical dependence, cravings, recurrent use that is all caused by opioids and how it impacts the brain. Okay, so let's talk about some statistics associated with opioid use disorder. So important thing to note is that about 20% of people, any kind of people from any kind of background, who are prescribed pain medications are said to develop an addiction to them. That's a large number. That's a really, really large number. Many people with opioid use disorder end up starting from prescription pain medications and then turning to other substances such as heroin. Heroin is about 10 times cheaper than prescription pain medications. That's like that. That doesn't even mentally compute for me. I think a lot of us people think, at least I do. I think that straight drugs are expensive, but no, heroin is 10 times cheaper than prescription pain medications. People develop a tolerance pretty quickly to opioids, especially if they're using them longer term to manage pain. And as a result of that, they need medications that are stronger. And doctors won't give them higher doses because they'll start worrying, hey, you've been taking this for a long enough time. We need to start titrating you off. I'm worried about you. And people will have no choice sort of but to turn to street drugs in order to take something that's stronger. And also, again, doctors are very, very hesitant nowadays to prescribe opioids. So what ends up happening is you get a prescription for a little while, develop an addiction to those medications, and then they're not available to you anymore. So people tend to look elsewhere. So per the CDC, opioid use disorder still has, and opioids in and of itself still has a very, very big impact on our nation. In 2022, we had 108,000 deaths due to overdose, and 75% of them were attributed to opioid use disorder. And we're going to speak about opioids and overdose right now. But essentially, opioids, because they have that depressing effect on the brain, they also slow breathing and slow our respiration systems down to very dangerous levels. So if we look at the causes of overdose, we're seeing initially that slow respiratory rate. It also slows heart rate, and those two things in combination lead to respiratory failure. There are a couple of risk factors that make people more likely to be susceptible to something like overdose from an opioid. The biggest one is using high doses. Fentanyl is 50 to 100 times stronger than morphine. So just a tiny little bit of fentanyl, someone might think that that is going to not work as well because it's such a small dose. But using a high dose and not knowing that it's a high dose is a very, very big risk of overdose. Mixing an opioid with any other sedative or alcohol can cause overdose. If you're using street drugs like fentanyl, that can, of course, put you at a higher risk. But also, if you're using any other illicit drug, or any drug that's not from a pharmacy, that can be mixed with fentanyl. Fentanyl is being used to mix with everything nowadays. So, college students will, buy Adderall on the street and it'll be laced with fentanyl, and they'll overdose. Low tolerance can cause overdose. So when people have, let's say, been to a correctional facility for a few months, maybe they've been to a drug rehabilitation facility for a few months and they come out and they end up using, they don't realize how much lower their tolerance is, they're at risk for overdose. Of course, other health conditions can increase people's risk and people's age. If you're older, you can be more at risk for an overdose as well. The most common opioids that are found to be involved in overdose cases, there are a lot of them, it's most of them, but methadone is one of the big ones, oxycodone, hydrocodone, morphine, and codeine, and then on the synthetic market, fentanyl and heroin. Of course, there are signs as well of overdose. If someone has slow, shallow breathing or they're not breathing, if you look and they're not breathing and you open up their eyes and their pupils are pinpoints, it's a very, very good sign that there is an overdose. If they have blue skin, especially their fingertips, their nails, their lips, and they're unresponsive, you shake them, you yell their name, they're not answering, that's another good sign. What we use for overdose is Narcan. And what Narcan does is it blocks opioids from attaching to those neurological receptors we spoke about 2 weeks ago or 2 presentations ago. So exactly where opioid works at the receptors on the brain, blocking pain signals, slowing respiration rates, slowing heart rates, inducing that feeling that's more euphoric, lowering anxiety rates, all of that stuff that happens right at the receptor in the brain. That gets blocked by Narcan. And so opioids literally stop working and the body systems can take over naturally. If you do ever administer Narcan, you want to call 911 right away, and you may have to that's not a good word. You may have to dose Narcan multiple times, because one dose might not be enough. So let's look at what that looks like. So this is what Narcan looks like. There are a lot of initiatives, especially in larger cities, where they actually hand out Narcan, especially college campuses, large metropolitan areas, as I mentioned, so that people can have it on hand to reduce this overdose epidemic that we're in. So it is, there are a couple of different ways people can get this. People can get injections if they are taken to a hospital, or if EMS come, they can give them an injection. But often what you're seeing on the street and what is given to people to carry with them are these nasal sprays. There are a lot of education initiatives. If you haven't seen one, I'm going to show you one right now, so you'll get a sense of that. where they have this sort of three-step process: lay, spray, stay, to administer Narcan. Lots of free resources happening right now. I think there are places that you can call if you need to or feel like you should carry Narcan at your clinic, where you can get those resources for free. And this link right here, I encourage you guys to copy that into your browsers and take a look at some of the education as well, because they have free posters, things like that you can put in your clinic that they can mail you. So this is one of those education initiatives, what to do in case of an opioid emergency. So laying someone down flat on their backs, tilting up their head to open up that breathing passageway. Inserting the Narcan, you can insert the Narcan in either nostril, it doesn't matter which one, pressing that plunger firmly to dispense the medication, staying with them, calling 911, and continuing to monitor them is so important for two reasons. One, if they're not responding and you have more Narcan, you can give them more Narcan. Sometimes people respond immediately. They'll like jerk awake. Sometimes they won't, and you can administer more Narcan. But if you're on the phone with 911, they can tell you what to do. The other important thing to consider here is that when people take Narcan, it can sometimes induce vomiting. So you want to stay with them so they don't choke on their vomit. So you can turn their head if needed, if they're vomiting. Okay. Let's talk about that intersection now. We've already been kind of talking about a little bit of traumatic brain injury and opioid use disorder. The main thing is that there are, and I'm sure you guys have kind of felt this already as we've been talking today, there's a lot of overlapping symptoms and a lot of overlapping risk factors for both TBI and OUD. So let's talk about those risk factors together to start. The first one has to do with pain and injury management. If you have a traumatic brain injury, you are often experiencing chronic pain, not just headache, but people tend to, after they have, if you think about someone falling or having a car accident, not only your head's not often the only thing that's hit, right? Maybe you injured your shoulder, your leg, broke some ribs. So people are experiencing chronic pain. They have what we call polytrauma often, and they're prescribed these medications. And the other thing with regards to pain and injury management is not everywhere, but there are some poor prescription practices that happen where people are prescribed, let's say an opioid plus a sedative at the same time. Or maybe one person is prescribing the opioid, another is prescribing the sedative, and not necessarily checking what other people are being prescribed. So that's a problem. There's also cognitive impairments, right? Whether you're taking an opioid and you have an opioid use disorder or you have a brain injury, we see that people struggle with memory in both situations. People struggle with decision-making and impulse control in both situations. And all of those situations can put you at risk for another brain injury if you're having impulse control issues and poor decision-making, and lead you to struggle to manage a substance if you're taking something like an opioid. Of course, both are, situations where people can have mental health conditions, so depression, anxiety, and PTSD. And if you have a brain injury and you're experiencing those symptoms, or if you have opioid use disorder and you're experiencing those symptoms, self-medication is something that a lot of people end up doing. There's not enough resources, there's not enough education, there's not enough money for appropriate care, wait lists are terribly long, and so people sort of take matters into their own hands. There are a lot of socioeconomic changes that increase people's risk, unemployment, financial instability, whether you have an opioid use disorder and that's happened as a result of risky use long-term, or if you have a brain injury and you've lost your job and you don't have any income coming in. And then, of course, like we said, limited access to rehabilitation for substance use. It's very expensive to get substance use rehabilitation, and it is also very hard to find rehab facilities that are without a long wait list for a traumatic brain injury, and again, leading you back to some of that self-medication. And then, of course, if you have a history of substance use, it increases your risk for traumatic brain injury. And if you have a traumatic brain injury, it increases your risk for the development of a substance use disorder. There are a lot of overlapping symptoms, for both traumatic brain injury and opioid use disorder. We see prevalent depression that persists over time and can get worse. Depression can actually change cognitive patterns. When we test people with no depression and no substance use history, and we test people with no substance use history and depression, we see that depression has its own cognitive profile. So depression can cause cognitive problems. If you're also experiencing cognitive problems because of opioids impact on the brain, or alternatively traumatic brain injury symptoms, these two things can make each other worse. Of course, when you have cognitive problems that is impacting your frontal system and you have that increased impulsivity, it can change the way you process rewards. So can substances. If you have all of these things and no access to care, your symptoms are going to get worse. That might alienate you from family and friends and other good decision making, lower your social support, which again will amplify those psychological symptoms, and on and on and on and on people will go. So ultimately, if you have TBI and OUD, those symptoms will increase risk of repeated use for opioid use disorder, and frankly, make you more susceptible to having another traumatic brain injury from something like a fall or a car accident when you're altered, and risk other types of acquired brain injury like hypoxia and anoxia because of overdose. The biggest thing to kind of think about and remember is the memory impacts, especially when we're thinking about treatment. Both people with TBI and people with opioid use disorder are going to have trouble with learning and memory. We're going to have that frontal systems pattern of behaviors where people are struggling with decision-making and impulse control, making it very difficult for them not to use substances and self-medicate. People are going to have more psychological problems and less support. And so we want to treat psychological problems and we want to increase support as much as we can. With all of the limitations, I think one of the biggest things that we can do as providers is provide education. If you can't provide treatment, provide education, because that's going to be really, really helpful. But ultimately, if you see these two things together, the concern is risk of repeated injury and greater risk of overdose. And if you see one of these things, know that there's a risk of the other, and tell people that there's a risk so that people can hopefully use that information to protect themselves. So let's talk about some of the barriers to diagnosis and assessment when it comes to traumatic brain injury and opioid use disorder. Well, we know, because we've been speaking about it, that there are a lot of shared clinical features. So there's a lot of overlapping symptoms. And what tends to happen is one or another of these diagnoses go undiagnosed and end up leading to treatment complications. So, for example, maybe someone is in substance use treatment, and they're struggling cognitively because of a historic brain injury, and no one knows about that, and they think that they're resistant, and they think that they're just not trying hard enough. And vice versa, there might be someone who's in traumatic brain injury treatment and they're on the outpatient side, and they may continue to self-medicate, and people are thinking, why isn't this, working? Why do they seem so unmotivated? But you can see these different types of symptom profiles that can really make it look like someone's not responding to treatment for whatever reason, but actually be symptoms of something else. People can also be misdiagnosed. Sometimes people can come in with a moderate or severe brain injury and they can be like, oh, you just had a concussion. It's probably not impacting you at all. Or people can have a delayed diagnosis. They can be in substance use treatment for a year and a half, really frustrated already, tired, thinking that it's not for them, used a ton of resources in order to get that treatment. And then a year and a half in, someone finds out this person, 2 years ago had a severe TBI. That can happen as well. What ends up happening most is that we're seeing patients who start in emergent care. Maybe they have an overdose from something like an opioid, maybe they have a severe traumatic brain injury. They start in the ER, and in the ER, people are not taking robust histories. They're getting the most important facts. What medications are you taking? Have you ever had one or two of these things? They're diagnosing on the fly. They're treating people. They're trying to keep them alive, and then people are going to intensive care, progressive care, and they're going home. And in that span of time, there is often not time or emphasis on getting a very robust clinical history because they're in emergent care. They're trying to save their lives. And so when we see someone with this history and physical that doesn't include these things. And sometimes we're not asking those questions as well. So there is ultimately lack of screening protocols, lack of training, and lack of planning when people are in treatment that continue to complicate this picture. So what tends to happen is there are not very many TBI and substance use screenings that are used in facilities. And when people are using screenings for substances, it's typically for alcohol use disorder. And that's a good thing. We're doing that because we used to miss that in the past. But there are other ones that we could potentially use that could make this better. And again, like I was saying before, some of the things that are most problematic is when people come into that emergency room and we're not getting that history of brain injury because something else is going on. There are, of course, provider training holes. AdCare and Brain Injury Associations doing such a wonderful thing with these presentations in order to try to make sure people are learning about opioid use disorder and traumatic brain injury, that intersection, and how we can work to solve these problems before they happen ultimately. But for many people, you can have TBI experts or substance use experts, but never TBI and substance use experts. And so this is something to kind of work on as well. There are a lot of gaps in knowledge related to those things, right? Because people are either a TBI expert or an OUD expert, they don't necessarily think about some of those intersections. They don't necessarily think about some of the symptom exacerbations. Maybe they're not thinking about how things are working really neurologically in the brain because of the type of symptoms that people are experiencing. So let's say, for example, anosognosia. People think, okay, I'm just going to tell this person, and they're eventually going to get it. They're eventually going to get that they have these symptoms that are really getting in their way. But anosognosia means that they're not going to have awareness of this thing no matter what you do. And it's a very, very hard thing to rehabilitate. It can be rehabbed, but it takes a very, very long time. And it's a very slow process. And it's going to get in the way of other treatments. And so those types of holes of knowledge can absolutely limit care planning for folks. And then I think one of the biggest things, and I'm sure all of us can talk about this, is that there are so many systems that we work within, right? And if you're working within even a large multidisciplinary hospital, even external places that refer to you, there can be lost communication. And when providers aren't communicating and they're not sharing what they're seeing, sharing something interesting, sharing something new, maybe sharing something like one of those signs we were talking about that someone might be developing an opioid use disorder, or something that might tell someone the cognition here for this person just doesn't seem quite right. I feel like there might be something more going on than opioid use disorder. Those conversations aren't happening often enough, and things are getting missed. And apart from some of these difficulties with diagnosis, some of these difficulties with proper planning and education initiatives and so on, there are still pain management dilemmas, not just for the TBI and OUD populations, but broadly with prescription practices. For TBI and OUD, one of my favorite websites, the MSKTC, Brain Injury Association of America, those are two good ones, giving you good facts about brain injury information. They share 72% of patients with TBI are prescribed opioids following an injury. 72%. That's 2/3. No, I'm sorry, that's 3/4. It's somewhere between 2/3 and 3/4. I'm not good at math. But that is a massive number of people. And these prescriptions are more common in more severe injuries because those are the people that are more likely to have something like polytrauma associated with their brain injury. And if they are also having a more severe brain injury, they're also having more persistent cognitive problems that even over time are not returning to baseline, right? And these folks are not only prescribed opioids, they tend to be prescribed other sedatives as well. And a quarter, at least, I checked that before I said it, of TBI survivors are going to develop opioid use disorder as a result of these features. So if you're seeing someone with a traumatic brain injury and you're suspicious about some of their new symptoms and you're wondering about it, screen, educate, and screen and educate until you feel like, okay, I don't have to worry about this person anymore. And another thing to kind of consider here as well is if you are seeing someone with an opioid use disorder and you haven't checked about their neurological history, do use a screener or just ask about the possibility of a brain injury in the past. So the problem here, the big problem here with opioids is that they work really, really well. Initially we spoke about this in our first presentation about how the opioid epidemic kind of started. But firstly, when they started coming out, people were like, wow, these work so well, and they were overprescribed. And then people realized people were getting addicted to them, so they started underprescribing them. And now they're trying to get to a place where there's a balance, where they can use this medication that works really well in a safe way. But the bottom line here is that anyone who takes an opioid can become addicted to that medication. There's some statements here from the CDC that I thought spoke for themselves, so I added them to these slides. In 2023, 125 million opioid prescriptions were dispensed to American patients. 125 million prescriptions. And in 2023, nearly 8.6 Americans 12 years and older reported misusing their opioid prescription. That's a lot. And please take a look at this picture. When I saw this, I was really taken aback. The size of some of these, especially fentanyl, one sesame seed. That's why when fentanyl is mixed or laced with other street drugs, people end up overdosing because it takes such a tiny, tiny amount. This is for a lethal dose. Sufentanil, I put this in the notes so you guys had it, recently approved by the FDA, 10 times stronger than fentanyl. And carfentanil, used only at veterinary clinics, but is smuggled into the United States and sold illegally. I mean, half a grain of salt, that's a lethal dose. This is scary, scary stuff. It's scary stuff because people who are using these medications, they don't know this. They don't know this. So there are multiple states that I looked at: Colorado, California, Rhode Island, Wisconsin, Maine, that have recommended safe prescription practices for opioids. I'm not a prescriber. I want to make sure that I share that disclaimer, but this is from a good lit review on safe recommended prescription practices. So some of the things that people are saying is if you do prescribe these medications, maybe consider using them in the hospital only after a serious injury or surgery, or using them with terminally ill patients. When you do use them, make sure that you are screening using something like the DAST, which is the drug and alcohol screening tool, which is nice because we still get that AUD screen, but we also get to hear about drug practices as well. And then, of course, there are TBI screens that we recommend too, like the OSU TBI identification tool. And then, of course, when you are prescribing opioids, people are recommending doing things like not prescribing for 30 days, making sure it's less, because that's how quickly it takes people to get addicted to opioids. Co-prescribing, something that can help with overdose. Really having discussions about addiction and risk and pain management options, and then incorporating behavioral health techniques like types of therapies to help with pain. Again, we know this, the pain management difficulties after TBI are pretty big. There's a huge risk of dependence. People have limited access to alternatives. And when alternative pain management options are there, they tend to be underutilized. So this is like CAM, complementary alternative medicine. So like yoga therapy, acupuncture, massage, those types of things. But there's a lot of stigma still. So even, when pain is legitimate, people with substance use disorders, don't get the prescriptions they need. And then conversely, sometimes people with things like traumatic brain injury are overprescribed certain medications because people don't understand some of the increased addiction risks that we've spoken about. And ultimately, the thing that could fix some of this stigma, this lack of multidisciplinary pain management, is still pretty persistent, us not talking to one another. So I'm looking at the time. Oh my gosh, we're still have a bit to go. So I'm going to try not to rush this. So to give it its due, but also apologies with the time. So there are a bunch of programmatic developments for treating comorbid TBI and OUD, but no formal programming that's been released to the public with evidence saying, hey, I created this TBI plus OUD program. Here's how long we've been doing it. Here's how it's working. Here's what we're going to change because here's what didn't work. Here's how you can replicate this. There are not a lot of those things out there yet. So if you're working on that, we're really excited to get to see it because we really do need a comorbid treatment manual for TBI and OUD. What we do want to encourage people who are thinking about developing these things is making sure that it focuses on collaborations between multidisciplinary teams to do things like reduce stigma, increase training, and share expertise about these two very serious disorders. When it comes to medication, make sure that your program includes things like education initiatives about medication and helpful prescription practices for people who are prescribing medication to these two populations. Also, make sure that it includes a combination of individual and group therapy options. For individual therapy, it's not a bad idea to have a neuropsych assessment if you have TBI and OUD, both conditions causing psychological and cognitive symptoms. You want to know what those are so that you can create individualized treatment plans that target what needs to be worked on, and keep in mind the things that might get in the way of someone being able to successfully move through any program. So you want to think about making sure your program uses things like motivational interviewing to help people who are struggling with motivation as a symptom, adapted workbooks and handouts for cognitive and sensory problems, and then really incorporating rehabilitation strategies if you're focusing on substance use disorder. And if you're focusing on cognitive rehabilitation, incorporating substance use education, and then safety for people with substance use disorders as well. For group therapy, make sure you are evaluating for readiness in a group. Groups work well because we have limited social support and we want to increase that social support, but we want to make sure that from a cognitive and psychological perspective that someone can deal with the stimulation in a group and communicate appropriately, especially when they're having trouble with social cues or social cognition. You can also have adapted and abbreviated sessions and content. So maybe you're doing a substance use treatment, but you have a session on memory strategies. You have a session on social communication. And then make sure if you're developing programs that a cornerstone of that program is related to education. So let's talk about psychoeducation initiatives. I think this is something we could speak about for a whole hour. We talk about psychoeducation a lot in counseling and psychology and behavioral health fields, but there are nice models for this. This is a model where you're sort of discussing any presenting concerns really very openly, and then emphasizing things that are important about those disorders. So when it comes to TBI and OUD, for TBI, emphasizing what recovery is supposed to look like based on the research, what people can expect. Emphasizing locus of control in opioid use disorder, what you can control, what you can't, if you are self-medicating, other ways to get symptom relief. You want to really encourage people to discuss and think about emotional and cognitive changes. So you don't only want to be the person telling people, hey, these two things can cause these problems, but open it up for discussion to see what problems they've experienced or noticed. You absolutely want to normalize some patient fears and post-injury behaviors. We spoke about stigma for medication. There is a lot of stigma when people have any behavioral changes after a brain injury, and even after substance use that people, can sometimes judge pretty harshly. So normalizing those things. Normalizing doesn't mean accepting. It means recognizing that it's there and it's common and there are things we can do about it. And then, of course, you want to highlight daily improvements, highlight management of triggers, highlight recognition of people noticing risks, right? Noticing risk signs and being aware of those. And then, of course, as much as you can, you want to involve any family or friends that are able to be involved and help them to encourage their patients to become more and more independent slowly and scaffold that independence. So that we're highlighting not just neurological, but functional recovery. And this is another topic that we can talk about for an hour and a half, how we can integrate cognitive rehabilitation strategies into treatment. If you are treating comorbid TBI and OUD, you absolutely want to have a component of cognitive rehabilitation or refer to someone who is a specialist in cog rehab. So speech therapists, neuropsychologists, some counselors, occupational therapists, all do cog rehab. This is a type of therapy that targets cognitive problems like attention or memory, and the goal is to improve cognitive abilities after something like a brain injury. And the goal is not just to improve those things so people do better on tests, so objectively, but to improve things so that people can gain functional independence. It's super research backed. There's a lot of evidence behind cognitive rehabilitation, especially compensatory strategies. So compensatory strategies are how to work around a cognitive problem. So for example, if someone has really bad attention problems from opioid use disorder and really bad attention problems from a brain injury, you can work on strategies to help improve people's attention. That could be as simple as incorporating mindfulness once a day. It can be as simple as being able to manage their environments to reduce distractions. It can also be maybe some attention exercises that they're getting on an app that they can use on their phone so they have day-to-day cognitive stimulation. So cognitive rehabilitation is a super important component if we're treating comorbid TBI and OUD. Another super important component with treating TBI and OUD, let's say someone is in substance use treatment, making sure that treatment has cognitive rehab as a component, maybe a couple of times a week, and then mood treatment a couple of times a week as well. So this is because we want to minimize that need for self-medication with opioids. We want to increase awareness. Of course, we've got time and true tested methods like cognitive behavioral therapy that works really well with anything mood related. There are other things too, of course. But CBT is super successful for depression and anxiety, has been used in the past successfully in tandem with substance use treatment. It is manualized. There are long-term sessions for 12 to 14 weeks, and there are even short-term cognitive behavioral therapies that you can use. And the nice thing is it's adaptable for neurodiversity. So whether you have someone who's coming in with opioid use disorder with a neurodevelopmental condition like ADHD, or you have someone who's coming in with a traumatic brain injury and their cognition isn't quite what it was, you can adapt cognitive behavioral therapy to help support any cognitive changes pretty easily, which is nice. CBT is actually so flexible for cognitive problems that they have done a study. I wish I had this study name. I should have popped it in here. But if anyone needs it, I can email it to Peggy and you guys can have that, where they did CBT for people with dementia who were having trouble with their memory. There are different types of dementia, and some of them affect memory worse than others. And these were folks who had trouble with memory, and CBT was successful even with them, even with struggling with memory, to help improve their mood. Of course, you also want to make sure that you're screening for different types of emotional presentations. Depression is a big one because of that overlap in OUD and TBI, but just as important is going to be trauma as well. So using things like trauma-focused CBT, and other types of modalities can be super helpful. And then also considering doing mood treatment in groups to get a larger catchment is going to be helpful as well. Many treatments for mood can be done individually or in a group. But ultimately, when you're seeing people with TBI and OUD, you're going to want to make sure that you're accommodating some of their behavioral changes, and just some different ways in how you approach things and approach treatment can be super helpful. So using trauma-informed care, speaking a little bit slower and using simple language can go a long way. In groups, especially when you're providing education or you're making a point, double down on that and use ample repetition. Again, like we said, every brain injury is different, so don't make assumptions about what symptoms might people have. Ask about it. Use that psychoeducation model. Provide those compensatory strategies, especially for memory and learning. That's going to be doubly impacted in OUD and TBI, but also going to be helpful across the board if anyone has any neurodiversity, to make sure that things are retained and that they can put that to use as time goes on. Make sure people do understand expectations. Sometimes people don't, they'll just say it. So use things like the teach back method, and then really try to help build self-awareness. There's lots of great free exercises on self-awareness if you pick up any TBI manual. I have one of my favorite ones. It's a little old and it was written, I think it's from the UK. This is what it looks like, the Brain Injury Workbook. And it's written by Trevor Powell. It's like $40 on Amazon. They have some exercises for executive functioning that I don't like, but some of their attention and memory exercises and compensatory strategy handouts are great. You can use that and incorporate it into your work. For attention and memory, when you have people with these difficulties in individual sessions, especially, help them by, limiting distractions in session. And if you're in a group, making sure that you are using things that can be used in a group, like asking the group for help, keeping language simple, using a catchphrase like, pink watermelon or something like that, if people are getting distracted, as the catchphrase for them to reorient to you. Setting up the environment, especially if you're in a group, making sure you're getting everybody's help. Like, hey, there might be folks here having attention problems, so let's set up this room together today so there are no environmental distractions. That's getting help, setting up, improving independence. That is a nice group activity, but it's also a really wonderful way to increase awareness about environmental demands and how they can impact your attention. Always review rules, especially if you're in group therapy. Every group bookend sessions by starting with saying what you're going to be doing and ending with saying what you're going to be doing. Make sure to follow an agenda and go slow. Incorporate lots of breaks, even in individual sessions if you're treating someone with comorbid TBI and OUD. And then consider multimodal activities. So make sure you're watching videos, listening to music, trying something where there's movement with the body so that your brain is able to learn in different ways, because different injuries impact people in different ways. Of course, when you are in groups or working one-on-one with someone and that patient is someone who has TBI and OUD, comorbid, they are going to have trouble with emotional regulation. So making sure that you are treating emotional dysregulation and talking about it, using things like grounding techniques, encouraging people to name emotions, to clarify their needs in the moment if they become very angry, irritable, or tearful. Asking what they need in that moment can be really, really helpful. And then really just assessing for the presence of other mood disorders that you may not have awareness of yet, so we can make sure that we're getting them all of the treatment that they potentially need. We spoke about this a couple of times, so I'm not going to spend too much time on it, but making sure that we are incorporating alternative pain management. And if you're not in charge of managing the whole treatment, talking about alternative pain management so your patients can be advocates for themselves and think about things like non-opioid medications, physical therapy, complementary alternative medicine, counseling like CBT for pain, and then really just education about opioids. And then, of course, we know this, but just to kind of double down on this as well, really thinking about individualized care. Um, Individualized care is always going to increase engagement. It's going to help touch on innate motivation. So even when people are having symptoms of a motivation, using things like motivational interviewing can help pull things that are still important to the individual, even if they can't find that behavioral initiation. And we can help with behavioral initiation more than we can help give someone a why, right? If we can figure out the why, that's really helpful. Focusing on patient strengths is very important, especially if we know that they have cognitive and psychological and behavioral symptoms associated with either TBI or OUD or both. So we want to make sure we're focusing on their strengths in those areas and accommodating for areas of change or concern. And then we want to make sure we're filling gaps. And the best way to do that is with individualized care. So if you are doing groups, maybe think about an initial assessment, a group, a post-group assessment where you're referring to other treatments that people still need, so that we can make sure we're highlighting the things that matter: social support, community resources, and then education. And then to kind of wrap us up here, making sure that we're thinking about advocacy as we do this work, especially when we're working to develop programming for comorbid TBI and OUD. Again, not a lot of programming out there yet that's coming to us with results, robust results, but thinking about the purpose of advocacy. Really, we're wanting to protect these vulnerable populations, and we saw those overlapping risk factors for TBI and OUD. We use advocacy to create change through education and correct misinformation, which is so important. Like I said, even if you can't treat, educate. We want to make sure we can be a voice for people who don't have one, and we can really promote as much access to care as possible. And then, as I mentioned before, when it comes to any new programming that you're developing, really emphasizing collaborations between treatment providers. There's a good chance you may have a bunch of the things we went over already, but you might not have, let's say, someone who's prescribing medication at your clinic. So we want to make sure we have these collaborations. We want to make sure that we're reaching out to the community and finding out who our stakeholders are to get funding to help support new programming and support education initiatives. We also want to expand education initiatives to where they matter. They matter everywhere, but things like schools, for example, the earlier the better. So like middle school, even making sure people understand the dangers of street drugs. And the fact that sometimes what you buy might not be what you get, and the risks of that is super important. And then again, really just encouraging community buy-in by taking stories to the community, taking initiatives, taking research to the community, and letting them know what you can do to protect the people in the community by creating programming to support people with TBI and OUD. Okay, I want to thank everybody. I know we went a little fast on those last couple of slides. I'm happy to take as many questions as you guys have, and I will hand it back over to Peggy.
Hey, Chrystal, thank you. Earlier in the presentation, the question came up, does taking methadone mitigate these symptoms? And could you explain its use and how long do people stay on it?
Yeah, that's a great question. I can answer only some of that question. So methadone does help, yes. And it can definitely, because it works in a similar way, but not the exact way, it definitely reduces that symptom profile. So people won't have as many psychological or cognitive symptoms long-term from the use of an opioid. I don't know what the treatment length of time is for methadone. Maybe Patty does. I don't know if it's a case where it's you sort of abstinent for a period of time and then you stop. Patty, do you know how long people are on methadone for?
I do not. I think it's fairly case by case, is my understanding, but it can be long term. We also have Suboxone that's used a lot up here.
Yeah. Yeah, it's used a lot and it's definitely used long term. I'm sorry I don't have that exact number for you, but absolutely will reduce some of those negative consequences neurologically and psychologically for the patient when you're taking that medication instead of using. And then, of course, it also puts you in the position where you're not compelled to use as much because you're taking a similar drug, which is getting rid of those really uncomfortable withdrawal symptoms.
Great, thank you, Chrystal. Another question came up. Can you please redisplay the book that you had referenced earlier so I can throw that in the chat for participants that asked?
Was it the book?
Yes,
Oh, yeah.
book on CBT.
And I can send it to you as well. It's the Brain Injury Workbook, Exercises for Cognitive Rehabilitation, the second edition by Trevor Powell.
Thank you.
Yeah, I think it's $40 on Amazon. It's a good thing to read through too. It's created for patients. If you're a provider and you're thinking about integrating compensatory strategies and education about cognitive change, it's a great place to start. You can print off the pages. It's with permission from the publisher to use in treatment, and you can give those to your patients as well, or have them buy the same workbook and go through that with them. It has a very nice section on adjustment to injury and working through identity changes, psychological changes, mood regulation, in and above some of those cognitive changes after brain injury as well. So very helpful.
Great. I don't think we have any more questions at this time. So thank you very much, Chrystal, for your presentation today. And also thank you to AdCare Institute of Maine for hosting the webinar. Also, I'd like to thank everyone that was in participation today. And I hope you all have a great day. Thank you.